Let's conclude by talking about intraaxial lesions, parenchymal hemorrhage and intraventricular hemorrhage. Intraaxial lesions are primary lesions. The injury is direct at the time of the impact or the event, and the neurologic effects should also begin immediately at the time of the impact. This is an important concept that distinguishes the extraaxial lesions, the epidural and subarachnoid hemorrhage, which very commonly are associated with the delayed neurologic effect. Cerebral contusion is a traumatic or mechanical disruption of small, typically capillary-sized blood vessels. There is an extravasation of whole blood. We have a combination, therefore, of red cells and plasma looking like brain edema. There is an admixture of blood and the native tissue at the microscopic hemorrhage, which may produce visible petechial hemorrhages, and that may create an appearance of a mottled or speckled or salt and pepper high attenuation, low attenuation mixture on computed tomography. Here is an example of grossly obvious massive cerebral contusions involving both frontal lobes, and the frontal lobes and the temporal tips are most commonly affected by cerebral contusion. If larger vessels are damaged, the contusion may produce more confluent collections of blood that may progress to frank hematomas. And just remember, a hematoma is a mass of red cells without intervening brain tissue, whereas a contusion is blood admixed with the brain tissue. There is a naming convention for cerebral contusions. A coup contusion occurs underneath or on the same side as an impact, typically associated with overlying skull fractures and or a small diameter contact point. At the opposite end, we have the contra-coup contusion, which occurs opposite a point of impact, classically associated with falls where the moving head strikes a broad, flat surface. And in between, Drs. Garfunkel and Simon have described the cuckoo-cachoo contusion, or the shearing injury, which we'll see later on as a completely separate subject. If we hit the patient in the front, we will typically see contusions or bruising involving the temporal tips and the frontal poles. If the patient is struck on the back of the head, we will also see typically contusions involving the temporal tips and the frontal poles. Classically, we understand that a coup contusion occurs when a moving object strikes the surface of the skull and the force is transmitted directly through the bone to the underlying brain. It's a little bit more difficult to understand the physics responsible for producing the contra-coup contusion. Contra-coup contusions are classically associated with the moving head striking a non-moving object, such as the floor or the wall, which typically would have a large diameter or an infinite diameter in the sense of being a flat surface. So cerebral contusions, again, are most common involving the frontal pole and the temporal tips. We can see here that there is intracranial air and multiple areas or foci of abnormal high attenuation involving both frontal lobes. We can see here in a different patient that we have an area of contusion in the right frontal lobe, but if you look carefully, you can also see that there is an area of scalp swelling in the opposite contralateral left occipital pole. So the mechanism in this case is contra-coup. If we look at the bone window image, we can see that there is a skull fracture. We have overlying scalp swelling over the patient's left occipital bone. Somehow the forces have been transmitted through the brain, which may act like a fluid medium, and has produced the petechial hemorrhage in the contralateral frontal lobe, again the classic contra-coup contusion. The prevailing theory about the formation of the contra-coup injury is that as the moving head strikes the floor, there is a tidal wave of CSF that produces a larger pool on the dependent side, and the forces are transmitted through that cushion to involve and affect the contralateral portion of the brain. But there is another theory to explain the occurrence of contra-coup contusions and the very common localization of brain bruising involving the temporal tips and the frontal poles. And that has to do with the surface of the brain that is immediately adjacent to the irregular surface of the skull. If we look at the roof of the orbits, we see multiple irregular bony ridges. We can also see that there is almost a knife-like or incisive edge to the lesser wing of the sphenoid bone that is aimed and pointed at the tips of the temporal lobes. And this patient also had an incidental tentorial meningioma. Regardless of how the injury occurs, contusions are documented to most commonly involve the frontal poles and the temporal tips, and they very commonly will produce hemorrhage and bruising that affects the olfactory bulbs and the olfactory nerves and the rectal gyri on the orbital frontal surface of the frontal lobe. So we expect to see this constellation of imaging findings when a patient has a traumatic brain injury producing the primary lesion of a contusion. If we look at the coronal image, again we can see how an imaging plane would be demonstrating these bruises involving the frontal lobe and especially involving the area where we have the olfactory bulbs and tracts. We must remember that we commonly evaluate the cranial nerves starting with the second cranial nerve, the optic nerve, but if we actually were to examine routinely in every patient the function of the olfactory nerve, we would find that the most common cranial nerve damage and trauma is indeed the one that we least commonly investigate, and that is the olfactory nerve. So this is a patient that smells badly, not bad, but badly, a patient that has anosmia. Cranial nerves 2 through 12 are intact, but the first cranial nerve has been damaged by this orbital frontal contusion. So a contusion is a parenchymal hemorrhage and is typically in the surface of the brain, and it is at the crests or crowns of the gyri, and typically does not involve the surface of the brain forming the banks of the adjacent sulcus. And if we look here at this gross picture of a patient who died with contusions, we can see multiple curvilinear flame-shaped hemorrhages that involve the crests or crowns of the gyri, while the brain adjacent to the sulci, which in this case also has subarachnoid hemorrhage, do not show a similar finding. So contusions are surface phenomenon. They are not going to be deep in a sulcus. They are not going to involve the full thickness of the gray matter around the convexity of the hemisphere. If we compare an acute image here with a subacute or chronic time frame, we can identify that the blood product methemoglobin produces T1 shortening and therefore is going to produce a relatively long-lasting area of hyperintensity involving the same regions of the brain. And by the way, these are two different patients. We must also talk about what has been classically described as shearing injuries, what we might more properly describe as traumatic axonal injuries. These, by definition, are deep lesions classically associated with high-velocity motor vehicle trauma, oftentimes associated with an acceleration or deceleration in the coronal plane with an element of angular momentum. This is exactly what you would expect if a car runs a stop sign or a red light and broadsides another car, producing the classic T-bone effect. You do not have to have an impact or a fracture, but they are very common in patients who have shearing injuries. And the discussion of shearing injuries typically revolves around a mechanical disruption of the axons, although it has been suggested that there is actually a tension and an excitotoxicity that causes autoamputation of the axons. But regardless of the actual mechanism in place, we have a disruption of the axons, and therefore we have a traumatic breakage in the wiring of the brain. What we most commonly image with traditional techniques in a patient that has a shearing injury is the secondary effect of the shearing of small white matter blood vessels that create very, very small punctate areas of petechial hemorrhage. So just as a reminder, the deep lesions are classically associated with coronal forces, and the lesions are typically small, usually less than 15 millimeters, and are in the subcortical parts of the brain, either at the gray-white matter junction or in areas like the corpus callosum internal capsule in the brainstem, where there is a high degree of organization and a parallel arrangement of the white matter structures. So in this traumatic axonal injury, we may see a variety of different patterns. We may see patients that have neurologic deficits that are extreme or neurologic deficits that are very mild and perhaps not identifiable by a routine bedside examination. Patients may have multiple subcortical lesions. They may have fewer lesions that are in the area of the internal capsule, and tiny lesions that involve the reticular activating system in the dorsal brainstem or involve the thalamus. All of these combinations may produce a patient with a profound neurologic deficit and some degree of coma. So in this coronal brain image, we might imagine that some patients, after having a coronal angular momentum, will develop lesions that are subcortical, lesions that are in the deep white matter, lesions in the thalamus, and also lesions in the brainstem. And again, this is a very, very complex set of neurologic possibilities, and in any particular patient there may be a combination of lesions. We must also remember that we can have hemorrhage involving the corpus callosum as a result of tearing of the small white matter blood vessels, because the shearing forces are affecting the transverse fibers in the corpus callosum. Again, angular momentum. We may end up then with multiple very, very small punctate areas of hypointensity on the T2 weighted image, more easily seen on T2 star images or some type of susceptibility weighted imaging. And if we see lesions like this involving the body, the splenium, or sometimes the genu of the corpus callosum, these are probably most likely part of a spectrum of traumatic axonal injury. And again, we have to consider that there may be other lesions in other locations. Perhaps the best way to identify the tearing of the axons is by doing diffusion, tensor imaging, and tractography, and a discussion of these techniques is beyond the time that we've allotted for this particular presentation. We must remember that a wide variety of terms are used to describe these deep lesions. Cuckoo-Cachoo contusions or intermediate contusions, shearing injuries, diffuse white matter injury, and diffuse axonal injury are all acceptable synonyms, even if they are simplifications. These patients, again, typically have neurologic symptoms and signs that begin at the moment of the impact. Some of them will have an immediate loss of consciousness. Some of them will have a persistent vegetative state. If the patients survive for more than 24 hours after one of these traumatic axonal injuries, histology of the brain at autopsy may demonstrate foci of hemorrhage involving the classic locations of the corpus callosum and brainstem, and we may be able to see that axoplasmic flow has pushed cytoplasm out of the truncated or torn end of the axon, producing an axon retraction ball. Longer-term survivors will demonstrate foci of demyelination, and there may be an influx of astrogliosis to produce microglial clusters around the sheared axon. Well, what is high velocity? I was expecting to find in reviewing the literature that high velocity would be 70 or 80 miles per hour, but in actual fact, if a motor vehicle is traveling at 35 miles per hour, that is sufficient in a T-boning coronal angular momentum situation to produce a deep lesion or traumatic axonal injury. So these lesions, again, are going to be less than 15 millimeters in diameter and do not involve the cortex, in contradistinction to cerebral contusion. They can be in the subcortical and hemispheric white matter, the corpus callosum. They may involve the brainstem, classically in the dorsolateral quadrant of the upper brainstem, the upper pons, and the midbrain or mesencephalon. If we consider what's actually happening physically in these patients, we are getting mechanical forces that somehow end up producing a disruption of the axons, and then we will end up seeing in these patients the puddling of the cytoplasm distal to the torn or truncated end of the axon retraction ball. And diffusion tensor imaging may directly demonstrate that there is a loss of anisotropy and that there is a loss of connecting fibers, but we may also see the secondary signs of hemorrhage when it occurs by doing susceptibility weighted imaging. Just for reference, here is a photomicrograph illustrating how the cytoplasm is bulging out as a result of a tear in the axolemma in a patient that died from a shearing injury. If we think about the names that we use, we want to realize that calling it diffuse white matter injury or diffuse axonal imaging is an oversimplification. These injuries are not limited to the white matter, but very clearly and commonly involve the gray matter of the basal ganglia and the thalamus. We must also understand that although some patients are in coma, there's many different kinds of coma, and some patients will not be in coma despite having had the same type of physiology of a shearing injury. Some of these patients may only have subtle changes on specialized psychometric testing. What type of MR imaging, and we must all accept that MR is far more sensitive than CT in identifying these lesions, what type of MR should we be doing? T2 weighted and FLAIR imaging may have insufficient sensitivity for these shearing injuries, but some type of T2 star imaging or susceptibility weighted imaging may clearly demonstrate foci of susceptibility artifact or change, in this case a very, very small punctate area of hemorrhage in the dorsolateral quadrant of the midbrain or mesencephalon, a classic lesion produced by shearing. So if we think about the shearing injuries, these are deep lesions very commonly involving the corpus callosum. We may be lucky and see evidence of brain edema or accumulation of water as a result of shearing involving the body of the corpus callosum. But if you imagine what's going on physiologically, these axons have been disrupted and torn, and we may also expect to see that there is hemorrhage in the same location. And this hemorrhage, again, is in the mid portion of the body of the corpus callosum, not on the surface. We want to emphasize that shearing injuries are not surface lesions. They are deep lesions. And this is a very important feature that distinguishes shearing from conventional brain bruising or contusions. Sometimes the blood and hemorrhage in the corpus callosum may rupture into the ventricular system, and we may have intraventricular hemorrhage. Sometimes we may see tearing of the perforating lenticular striate blood vessels, giving us foci of hemorrhage that involve the basal ganglia. In fact, without an appropriate history, a ruptured lenticular striate artery produces a confluent hematoma in the basal ganglia that is virtually identical to the same type of hemorrhage that occurs as a result of hypertensive vascular disease. But in the same patient, we can also see the classic hemorrhage involving the mid and inferior portion of the body of the corpus callosum, suggesting that these lesions are both the result of the same cause, a traumatic brain injury. So let's conclude by seeing how this works in the real world. We have a 26-year-old man transferred by Aerovac after a helicopter crash. Upon arrival, the patient was intubated and sedated. Clearly, the patient was having an altered mental status and an altered neurologic presentation. Appropriately, a CT of the head was performed as part of the trauma evaluation. Here is the CT scan of this man in coma. We do not see, we do not understand, there is no explanation on this image for the patient to be in coma. There is no herniation, there is no midline shift. But if we think about the causes of coma, there are physiologic and metabolic conditions that may cause coma. There are structural and anatomic lesions, which is what we're looking for on our imaging. And there are many different types of coma that can be caused by lesions in many, many different locations. But if we get back to our patient who has a clear-cut history of trauma, we want to look a little bit more carefully and identify that there is a small amount of intraventricular hemorrhage. Intraventricular hemorrhage may have a more innocent cause. It may be related to a tear in the choroid plexus, but it should be a tip-off that more sensitive imaging is needed. And when this patient had an MR scan done with a gradient image sequence more sensitive to blood, we identified not only the dependent layering of hemorrhage in the occipital horn, but two other foci of hemorrhage, including one in the thalamus. And remember, hemorrhage in the thalamus, lesions in the thalamus, may also cause coma for our patients. If we look higher up, we also see the classic lesions involving the mid-body of the corpus callosum. We did not identify anything in the corpus callosum on the CT scan. In this particular case, the lesion is large enough to cause an abnormality seen on T2, as well as the classic areas of T2 shortening seen on the gradient recalled image. And again, these lesions are sufficient to produce the coma that was identified in this patient. Here is another unconscious patient. This CT scan was originally described as being relatively normal. I think we can all appreciate that we do not identify sufficient sulci, so there probably is some degree of brain swelling. But there is a dramatic number of lesions that we can readily identify on routine FLAIR sequences involving the area of the hippocampus, the dorsolateral quadrant of the upper pons, involving the splenium of the corpus callosum, the adjacent areas of the thalamus, and also involving the basal ganglia. So we must remember that what we have called diffuse axonal injury is not just limited to the white matter, but also involves the deep portions of the gray matter at the same time. And certainly these lesions involving the thalamus and the brainstem may be the cause of the patient to be in coma. And this is the same patient now with susceptibility weighted imaging, and again we see the punctate foci of T2 star effect caused by microscopic hemorrhages in exactly the same locations. So this patient has certainly suffered from a shearing mechanism or a traumatic axonal injury. So when the patient survives the acute presentation, we may have the formation of hemosiderin. Hemosiderin is the black magic marker of hemorrhage in the brain. Hemosiderin is never cleared through an intact blood-brain barrier, and the foci of hemosiderin will be a lasting reminder that this patient has suffered from a traumatic brain injury. So let's summarize what we had a chance to talk about in this presentation. We discussed who needs imaging. Any patient who has a neurologic change that was preceded by a traumatic event. We talked about lesions that infect the skull, lesions involving the scalp, and epidural hematomas, and that not every epidural hematoma needs to be drained. As a reminder, subdural hemorrhage can have a delayed presentation, and therefore there may be a variable appearance in the hemorrhage. We may have degradation of blood products. We may have blood that is in various states of chemical composition that alter the MR signal intensity. We talked about contusions or brain bruising as being surface phenomenon, either directly under or contralateral to a point of impact, and contusions are associated with a contact injury to the brain. And we finished up by talking about shearing injuries, which by definition are below the cortex deep lesions that may be associated not only with coma, but all kinds of complex and intertwined lesions that may be identified on psychometric testing. Thank you very, very much for listening to the entire presentation.